Good evening, everyone, and thank you for joining OSC's lecture tonight with Dr. Carlson. My name is Chelsea, and I am part of OSC's marketing team. Tonight, I'll be interviewing Dr. Jeffrey Carlson to help you learn more about disc replacement and if it might be right for you. Dr. Carlson has been with OSC for over 20 years, and serves as the president and managing partner of Orthopaedic Spine Center. A fellowship-trained orthopedic surgeon, he focuses on spine care. Tonight, I'd like to help me welcome Dr. Carlson. Just put a quick hello in the chat. If you can see the Q&A, go ahead and just put that in there so we can say hello to you. Good evening, Dr. Carlson.
Good evening. Hope you can hear me well.
I can. Thank you.
Wonderful. Glad that we could be involved and we can talk about some important issues, especially through a conference like this, where we can have the technology to be able to even talk to people and to get information about medical care that we need to get out anyway. Medical problems and issues all continue to happen even throughout a pandemic. So we still have disc herniations and pinched nerves and medical issues that need to be taken care of. So if we can get that information out to people, I think that's great.
Fantastic. I'm going to share my screen with you right now so that you can start to see the evening, what we're going to be talking about. I do want to go ahead and move to the Q&A slide. Dr. Carlson will be taking questions tonight throughout the talk. If you have a question, there are instructions on your screen about how to ask that question. Just go to the Q&A little screen at the bottom and type in your question. Make sure you hit submit. We're going to hold on to that question until we find a good stopping point or near the end of the lecture when Dr. Carlson can have time to make sure he addresses your question. I do want to go ahead and Dr. Carlson lead with a very pressing question. This year is being defined by COVID-19, and many patients have expressed concerns about receiving the medical treatment that they need in a pandemic because of the virus. So can you tell me what OSC is doing to protect its patients, its staff members against COVID-19? And what would you say to someone who is sitting at home right now in pain, waiting for COVID to pass before they seek out care?
That's a very good question. Obviously very pertinent, especially in tonight. Like I say, using this technology now, this is great to be able to do this, but there are times when you need care. Medical issues still happen. And so we still need to get that care, still need to have that personal interaction with physicians and staff in order to get the x-rays, right? We can't do x-rays over the phone. We can't do injections over the phone, treatments like that. And in orthopedics specifically, a lot of what we do is the physical examination, be able to make sure that the disc herniation matches with what's going on. Is the arthritis, is the pressing on the nerve root? Where do we go with that next? And giving that information face-to-face to patients. So we've changed a lot of our processes here in order to get to a point to keep our staff safe, but also keep our patients safe. Obviously, COVID's got our hand in everything right now. So from our office standpoint, we'll have you come to the office. You can actually set your appointments up over the phone. We can do that over the internet. We have ways in order to set your appointments up online, so you don't have to interact with people as much. And then we have a way to check in at the office online as well. So through a texting app, we can text you. You can text when you're here. We can text you and tell you that we're ready for you, so you don't have to sit in the waiting room or around other people. Sit in your car, relax, listen to the music there until we're ready to have you actually come in, get your x-rays done, and see the staff that's here. Part of all that, of course, as has been mentioned numerous times, and hopefully everybody's already got this, we're wearing masks and we're doing cleaning. We're making sure that each room is clean before you get there. After you leave, we're cleaning it up for the next person. The office is cleaned every night. We've got the cleaning staff that has specific chemicals and specific treatments to be safe for coronavirus, to make sure we eliminate that and make the areas that our patients are seen sterilized again. So we're trying to keep our staff safe. We don't want people getting sick on our staff because they take care of us, and we want to make sure that we have those first healthcare workers taken care of, and then taking care of those vulnerable patients that are coming in to see us. We don't want to have any spreads related to that. So we're very, very conscientious about that. So we really don't want you putting off care. That's one of the issues with coronavirus specifically, is it makes you concerned about going around other people. And if that means that you're going to sit at home and still suffer in pain or have other medical issues, we think about having back problems or neck problems where you limit your mobility, you can end up with other issues, pneumonias or blood clots and things, because you're not seeking the care you need for your current problem. So we don't want to add problems. So feel confident we're taking care of the facilities here and our staff and trying to keep you safe and doing all those steps in order to make sure we limit the ability of that to spread and limit the possibility of transmitting the virus to those folks.
Fantastic. I see our team, they're constantly cleaning, and the check-in system has really streamlined. You go right from outside to your room that's been cleaned, and that's really helped streamline things. And even tonight, this socially distanced idea is very different to have a lecture in this manner, but we're so glad that we get to come to people in their homes and give them the information that they need, very valuable information for them to help consider what's best for their care. That's really exciting. We're going to get to the meat of the lecture tonight, what we're here for. Dr. Carlson, can you start by helping define cervical disc degeneration for us?
Yeah, so the basics of that, cervical disc degeneration, a lot of words put together, but cervical being the neck. The disc, of course, is that space between the two bones. So the cushion, we call it, or the cartilage that's between the two bones. It acts as a cushion that's there. Think about it like being your brake pads, that's cushion between the two bones. And the degeneration, or basically arthritis. So the disc wears out with time. So with time, as the disc wears, we call that arthritis or cervical disc degeneration. As the disc wears, and this happens in everybody, we all, as we age, as we add more birthdays, we'll continue to wear things out. All of our bones tend to wear with time, and our disc wear with time. As that happens, the disc sort of collapses. So kind of like thinking about pressing on top and bottom of a marshmallow. As that collapses like that pressure allows the disc to bulge. We call that a bulging disc. And that's basically arthritis in the neck. As that disc continues to bulge, or the disc continues to degenerate, become more and more arthritic, the bulge can get worse, and you can end up with a disc herniation or a rupture of the disc. And that actually pinches the nerve root and will give you pain. We call it radiculopathy, or pain in a specific nerve root going down in a specific distribution into the arm. And it will happen one side or the other for a disc herniation. So you can have a disc herniation have centrally in the neck, and that can be what we call spinal stenosis, where it actually pinches the spinal cord. But more commonly, we have this radiculopathy or nerve pain related to the pinching of the neck, of the nerve in the neck. I get those questions as well. It's that I feel this pinching sensation in my neck. Pinching pain is not nerve pain. So nerve pain, electrical kinds of sensations going down the arm, numbness, tingling, pain shooting in a specific distribution. So each disc has a specific nerve root that it will pinch. So if we think about the C5 nerve root in the neck, it happens when the C5-6 disc ruptures and pinches the nerve root. It goes down specifically to the thumb, index, and long finger, and you'll get numbness and tingling and going into those three fingers. And by our physical examination, we can tell generally which disc it is that we're looking for. We also marry that up with your x-rays and see what the x-rays show. Do you have arthritic changes at C5 and 6 that would account for what's going on with your hand? And then further evaluation with MRI scans, CAT scans, those sorts of things. Neck pain is the original, right? Neck pain is from the arthritis, the wearing of the disc space itself. As the disc wears out, before it ruptures or before it pinches the nerve root, you'll get pain as the bones rub and grind. As they rub and grind, you get neck pain. So you pain in the back of the neck rather than the front. So the front of the neck, there's lots of things there, the esophagus, the trachea, those sorts of things. That's where the discs are actually in the front of the neck. But we get basically back of the neck pain from muscles responding to the bones grinding. When the bones grind, it makes the muscles spasm to try to hold that in position and keep it from grinding and try to decrease the pain. So initially what we'll try to do is we'll try to use some medication, something to inflammation, sometimes steroid pills, anti-inflammatory medications, those kinds of things to get the pain better, get the inflammation better. Muscle relaxers can also be very beneficial to stop the spasming in the neck and stop some of that acute pain that happens in the back of the neck. If or when those things don't work, then we get more invasive by doing injections. Cortisone injections, we call it an epidural steroid injection, or a cortisone injection in the neck to decrease the irritation, inflammation around the disc and the nerve roots are there. So that injection of cortisone is a local injection of the medication right specifically around the disc, so it helps stop the inflammation around the nerve and around the disc space itself. If those things get that calmed down, get the inflammation, the pain better, then we can use a physical therapist, a chiropractor, those sorts of things to maintain that position, to take the pressure off the nerve roots and get you feeling better. Now, disc problems, arthritic changes are very common. Right? Lots of folks, about 2/3 of the country will have some disc problems with time, and that's almost 48 million people having severe pain in the neck. And we're not talking about just waking up with a crick in the neck. This is 3 to 4 weeks worth of pain in the neck, and it's seeking care because it bothers you so much. When all those things don't work, right, the medications, the injections, and therapies, that's when we start thinking about surgeries. What do we do in order to get you out of pain? We're talking about arthritis, right? This is not things that are life-threatening, but life-altering. A lot of people can't go to work, can't concentrate because their neck is killing them, their arms are killing them, or they've got weakness related to that pinched nerve causing that pain down into the arm. They can't use their arm to do their normal daily activities or going to work and lifting and carrying things because their arm doesn't work like it's supposed to. And that's when we think about doing surgical interventions, taking the pressure off and removing that pinching of the nerve root to fix that for good. There's 2 ways of doing that. One is with this sort of the standard that's been around for a long time, we call fusion. When we do surgery on the neck, the idea or the whole goal around that is to take the pressure off the nerve. So when we go in through the front of the neck, you can actually almost feel your cervical spine from the front down through the side. When you do that, you'll find that disc is right in the front of the neck, right behind the esophagus and trachea. We can move that over and we can take that whole disc out, take the pressure off the nerve root all the way from the front. We don't have to cut any muscles when we go in through there. We just move everything out of the way. After we've taken the disc out, we've taken the pressure off the nerve root, which is the goal, right? To take that pressure off, fix the pain related to the disc herniation, and fix the nerve dysfunction. After we've done that, there's 2 ways we call reconstructing that. So now you have a space there. You've taken all that disc material out. You have a space. We want to fill that space with something. And the typical has been, we call fusion, basically filling that space with a bone graft and putting a plate on there that holds that together. The bones then grow together and that fuses. That becomes one solid piece of bone that's not going to move. However, recently we've been doing what's called disc replacement, similar to what you see in a knee replacement or a hip replacement, where we wouldn't think about fusing your knee for arthritis, or we wouldn't fuse your hip for arthritis, but we would take that bad joint out, the hip or a knee, and put in something that's mobile so you can walk and move. In a disc replacement, we've taken that disc out, taken the pressure off the nerve root, and now we're going to put in something there that moves, that actually has the same function of the disc itself that we've removed, but now not pinching the nerve anymore, but allows your neck to move and function as it would prior to having the surgery done, prior to having the disc rupture.
And that leads right into our treatment options. You've gone through some of those there. What is the M6 disc replacement, and how does that fit into the treatment options?
So the biggest thing about the M6, and I've got some models here. So we think about the disc itself. This is a kind of a rudimentary kind of way of thinking about a disc, how the ball and socket kind of go together and allows us to move back and forth, side to side, and actually rotates a little bit as well. Just a model of a disc and how disc material works. So if you think about a bone above and below, and then a cushion between to allow that to move, allow that to function and move your head, turn it up and down, and rotate. The M6 disc is basically trying to recreate that. So you see on the picture there, that's the disc replacement. So it has two metal plates, one top and bottom, and there's little grooves that are in there. Those grooves allow those plates to be fixed into the bone immediately. So it holds them in position. Between those two is the disc material itself. So it's a material that's made of cords, so it allows it to move back and forwards, side to side, front and back. So it allows it to function just like a normal disc would. It has the same motion. Okay. You can see that from the side, same motion that's there, moving front to back. As you bend your head forward or bend your head backwards, that disc material, the central portion of that, the nucleus, you would say, in the middle there, allows it to move. Because of the tethers that are here, and you bend backwards, it gets tighter in the front. You bend forward, it gets tighter in the back. It keeps it from moving too far. So this specialized material that's used in this allows this disc to function almost exactly like a normal disc because of how they designed this in engineering-wise. So this becomes almost an exact mimic for the disc that we're taking out. That kind of technology then forces or allows our neck to not force the other disc to be more mobile. If you think about a disc fusion where we're going to fuse the bones together so they don't move, that kind of forces the discs above and below to do a little more motion. And you could think that that may cause some problems in those other discs as we age. Because this is replacing that specifically so it acts like a normal disc, then we shouldn't have those problems above and below and not put more pressure, more motion, more stress on the discs above and below. The idea being that we can preserve your neck longer, so we're not having to do more surgery on another disc above or below within the next few years, because basically your neck is back to a normal functional motion than when we started.
Wow. Now, why Orthofix and the M6? Can you explain a little bit about what we're seeing here too?
Yeah, so this is a progression of the disc, kind of the ape man to the businessman kind of thought process there. From the far left of that, the disc replacement there is actually a ball and socket. It's like I say, the rudimentary kind of thought process here, right? A little ball in a socket allows it to move, but it's unrestricted. So that area that's there, that piece can move quite a bit. The ones that are down to the bottom and the top there, those discs are a little bit different in that they have several pieces. They got 3 pieces that are there. They are set into the bone. Those little keels or little divides that we have at the top and the bottom, they actually go into the bone and get malleted into the bone. So they provide immediate fixation. But there's a little plastic piece that's in there. So that little plastic piece is what allows that motion. You think about the gaskets that we have in cars or moving your hinges around, those sorts of things. That plastic on metal can be very, very slick. So that's the idea behind this. It allows it to move more smoothly, but it is a couple pieces. And in plastic specifically, you can get some wear. So the disc material that's there, thinking about a hip replacement or a knee replacement, those pieces of material there, the plastic is a part that wears out with time. So there's the possibility that those pieces of plastic will wear out with time. Not very common, but there's that risk. It also has more motion again. It's more motion than the standard neck disc is, and the cartilage that's there. So the disc itself is more restricted than what we see in these disc replacements, which gives us the M6. So the thought process as this grows, it comes to that next generation of discs that allowed become more and more constrained, more and more like the disc that we're replacing. So it acts more and more like our natural disc. And we like our natural disc. We like the way our discs move currently. So if we can mimic that and provide that same stability without having a disc rupture and without putting the pressure on the top and bottom of the disc above and below, then we really gained a lot. So each of these iterations are getting better and better with time as we find the science behind this and creating better and better engineering abilities to create a disc that mimics or reproduces exactly what our cervical discs do now.
That's fantastic.
So this is looking at it from the cross section. and why this is important, right? We saw those with the plastic. So this specifically looks at a cross-section of the M6, right? So this is that same one we're looking at here with the fibers are around it on the outside, creating what we call the annulus, so that covering around the outside. Inside is that bit of plastic that's there, but it's so dense and so tight that it's there that as it moves, it acts more like the central part of the disc. So if you look at on the right side there, that's an image or a picture of what the actual cervical disc looks like. So the central part of that's the nucleus, similar to what the M6 has, and then the outer ring we call the annulus. And that holds that central nucleus in position. That central nucleus is what ruptures. So when you have a hole in the annulus, you have a covering, that hole in that covering of that nucleus, then you get a rupture of that nucleus. We call it herniated nucleus pulposus or a disc herniation. So they've created the M6 to be very, very similar to that. So it recreates this same anatomy that we have in our natural cervical disc and allows that same natural motion that we have in our natural cervical disc. Reproducing that motion, that stability, is what allows our body to recognize that it feels normal. It feels like a regular disc. It doesn't feel like we've had significant surgery or stiffness that's there around this, because now this moves exactly as our normal disc does, and we have the same sensations and motion that we would with our normal disc. And we've also fixed the problem. We fixed the disc herniation, the ruptured disc that's pinching the nerve root as well.
Now here is just a short video that shows how it works. I'm going to go ahead and press play. There is no audio, so you can talk over that if you want to tell us what we're looking at, but this just gives us a little example.
Yeah, so this is going from the front. So this is exactly the M6 that's there, right? So it's mimicking that motion that's there, side to side, front to back, and rotation. So that disc, because of how it's designed with the fibers on the outside and that nucleus in the middle, allows it to take some compression, allows it to rotate, allows it to flex and bend just as a natural normal disc would do. So it provides, through that engineering of that of the disc space itself, it makes it work and function just like a natural disc would do. Again, because we fixed the current problem, the other discs aren't bad. We fixed the arthritis that's there, so we allow your body to function as it would normally again.
That's fantastic. Now, what is the next thing would be the evidence for the M6 artificial disc, cervical disc? What is the evidence supporting this as a viable option for patients?
Yeah, so this is, as we've seen, there's been lots of iterations of disc replacements over time, finding better and better engineering, better technology and science to build better disc replacements, right? So with time, we know that taking the disc out and taking the pressure off the nerve root fixes the nerve problem. We know the fusion is there as a way to provide stability. But the fusion is there only because we didn't have disc replacements. We didn't have another way to fuse the bones, another way to keep the bones from moving and allowing those discs to collapse, because we need to do something. We need to replace that material that we took out, the cartilage and the disc that we took out. So with time, we created the disc replacement. So now with the M6, there have been several different articles about how the disc works. The biggest thing is improvement in pain, right? We're going to do take the disc herniation out. And after we do that, that should fix the arm pain. We also want to fix the neck pain. So in the M6 studies, looking at 90% of patients that had significant improvement in their neck pain and arm pain. And that's compared to about 80% of patients with actually having a fusion. So the fusion does work with the arm pain. That takes the disc out, takes the pressure that's there, but the motion's not normal. So that's why that difference with 10%, because now the body doesn't know there's something foreign in there. It feels normal, so it's allowed to move more normally. And your nerves that are around there, the muscles and tendons that support that, also feel that that's a regular normal disc. So that's awesome. When you look through that, you also see, kind of the meaningful improvements on decreasing in pain medications. So you're seeing significant decrease in pain medication, right? If our big purpose is to make your pain better, we want to see you decrease your pain medication. So if we can get you off the pain medication, especially with the opioids being such a dependent kind of a medication, and there's so much disability that goes along with opioids and dysfunction related to that in families and in patients. So we want to try to get you off of those things. So if we can decrease that pain medication use, you can see the difference there. About 38% of patients still on some sort of medication, opioid medication, at about 2 years after surgery, and only about 14% of patients being on the opioid medication 2 years after the disc replacement. So that's a big jump, and trying to get you back to work and back to life. We think specifically about those folks that cannot be on opioid pain medications, drivers and truck drivers and folks that operate machinery. You shouldn't be on pain medication. So we can get you a better place that you don't need that medication anymore, and a significant decrease there. That's a big help in getting you back to work and getting back to life.
Absolutely. Further
through that, now we find that we look at the number of patients that improve their neck pain. So 9 out of 10 patients with the M6, in about almost 90%, more than 90% of patients that had the M6 had a much better result as far as their neck pain is concerned compared to those with the cervical disc fusion. So that's also a big jump from 8 out of 10 to 9 out of 10. That's a big number. And so trying to get patients neck pain, right? That's the reason why you went to get the surgery done, to fix your neck pain, fix your arm pain. Lastly is patient overall satisfaction. So we can get your arm pain better, get your neck pain better, get you off the pain medication. We can see those numbers, 93% satisfaction with having the disc replacement done. That's great news, because we're shooting for that, 98, 100% if we can. Is that really likely in life? Are we going to be able to do that? There's always going to be some that don't get there, but if you get a 93% satisfaction rate for patients, they say, I would do this again because it really changed my life. Those are big numbers, and I think that provides a good overall view of how patients feel after they've had the disc replacement done. So these are good studies. These are done scientifically in order to provide that information and the difference between a fusion versus a disc replacement. So big information.
That's huge. I do want to interject here and just let you know this is the final opportunity to enter any questions that you might have for Dr. Carlson. Just to give you a moment to type those questions in, we're going to cut to a short video. Earlier this week, we sat down with a patient of Dr. Carlson's who had an M6 disc replacement and just asked him about his experience. And this is his story.
My name is Marvin Carlson. I'm the owner of Degeneration Cakes. I want to say a accident survivor. I'm also a disabled veteran as well. So I have a history of surgeries. This was probably the most successful by far of the past surgeries. That includes hip replacements as well. It was simple. I just went to pick up a bowl of batter, and I wasn't moving it very far, and I just dropped it, and I was stuck. He suggested a fusion. Again, I had to wear that neck brace that I hated for 10 days. It took about 2 months of good physical therapy, and I was back. I was back in the kitchen or what have you. But I also have a condition from past experiences called idiopathic avascular necrosis. So that means once a joint is damaged, it tends to jump to other joints, and so you'll have problems with those. They'll tend to die or what have you. Then about a year later, I started getting that same tingling. Wasn't down the left arm, was always in the right. It's always like left arm, we got a problem. So it was always in the right, down the back. And he took a look at it. He says, I think, he said, I don't really want to do another fusion. He said, we could. He said, but I think I have something that you could use. He said, I know you like to play golf. I know you love to fish. And I know you love to bathe. So I think I have something that's going to give you full range of motion. And he said, it'll take a little time to heal because you pretty much just had a fusion a year ago. He said, but I think you'll be happy with the results. has to be a success because we're here talking. So, yeah, that's a little bit of my story there.
All right, through that video, we did get a couple of questions. So I am going to go ahead and read those to you, Dr. Carlson. The first question we have tonight is, what is the projected durability? How long will the M6 replacements, or how long are they expected to last?
The M6 doesn't have the same kind of complications or risks that the earlier disc replacement had. We had metal on metal, so like say, it's kind of like a hinge where that metal rubs on the metal, and you wear a little bit of that at a time. Or the plastic on metal, like a hip or a knee replacement, where that plastic will wear a little bit at a time. They put through those discs through studies and find just a little bit of wear, a little bit of plastic shedding off, a little bit of metal shedding off. The disc replacements of the M6 don't have either of those. So this looks like it's going to last a lifetime. Doesn't seem to have any of the wear characteristics of the disc replacements that are metal or metal on plastic. So far, it looks like we're going to be a lifetime replacement on the disc. Obviously, they're just getting this thing started in this country in 2019, but they've been doing it in Europe for thousands of discs that are over there since 2008. So they're continuing to increase those numbers and not having the problems with wear as they do with the other types of disc replacements.
Wow. What is this approved by insurance? Is this something that is not approved? How does that work?
That's a good question. It's been years now of getting to a point where we can actually get insurances to pay for disc replacement. So back 10 years ago, it was really hard to have disc replacement paid for by insurance. Some folks would pay for it out of pocket because it was a good procedure. These days, most insurances are now covering it, so we're able to get insurance to cover it. They see the value. They see what this means to their patients. They see they're not having more surgery. They see, as we saw in Marvin's story there, he had a fusion initially. Didn't like that because he needed to work. He had to get back to life, and he was restricted on his work for about 6 weeks. With disc replacement, he was able to get back to work at 10 days. So he's back to doing his normal job, baking again, and providing for his family because he's got a stable, mobile disc in his neck again. Even after the car accident didn't jar that out of position 3 months after his surgery. It was stable and solid in there. He was able to get back to work. Soreness from the accident, but able to get back to work and life, and he's doing all he wants to do now. So that kind of stability and motion that's there really provides for the insurance companies to understand that this is going to work, and this works as a reconstruction rather than a fusion. There's always that risk in patients with fusion that another disc will go bad. This has less of that risk because you're providing that motion that we need in order to maintain the function of the disc and to have each disc taking its little bit of pressure off of the neck. So insurance companies are recognizing the value in doing disc replacements.
That's great. The next question is, would I regain my strength? I have a lot of atrophy in my right shoulder, about 38% strength reduction from the right hand to the left shoulder as I work out with dumbbells.
So the strength itself is a process of atrophy related to the nerve being pinched. So the longer that nerve is pinched, the more likely it becomes permanent. So we want to get that fixed as soon as possible. So if you get the pressure off the nerve root as soon as possible, the more likely you are to have that function return. It does take some time. If you've got that much of an atrophy around a deltoid muscle or triceps, a biceps muscle, it's going to take some time to rebuild that. But if we think of the nerve as a water hose, if you pinch the water hose, you can't get that water to flow. If the nerve is being pinched, you can't get the information to flow down to your arm. So you've got to get that unpinched first for the information to flow down to your arm. So get that fixed, get the pressure off the nerve root, and then we can work on all the other stuff, especially the strengthening. There are times when the nerve root has been damaged by the disc herniation, and some of that will not come back. Again, the reason to get the surgery is to try to get this pressure off as soon as possible so you can recover more quickly and more fully, so you don't have any permanent damage to the nerve root.
Great. The next question is difference. What is the difference between an orthopedic surgeon and a neurosurgeon, and can a neurosurgeon install the M6?
I'm sure they can. The difference between an orthopedic surgeon and a neurosurgeon really comes down to their training. A lot of the training in neurosurgery is done around the brain, around the head, to work on aneurysms and strokes and those sorts of things, so bleeds that happen around the skull and around the head. In orthopedics, our training is done in motion, and so if we do, say, a hip or knee replacement, we want to try to get you back to life and back to sports. So if you have an ACL reconstruction, that's going to be done by an orthopedist whose job is to get you back on the football field. Same thing happens, the same thought process happens in surgery of the spine. So in surgery of the spine, orthopedic surgeons are really focused on getting you back to life, back to function, back to doing the stuff you want to do. So the whole goal there is to get you fixed. A lot of these surgeries are done as outpatients. So a surgery itself like this takes about an hour. You go home the same day, should be pretty well back to normal by about a week or 10 days after surgery. With time, of course, we work on like the gentleman asked about the muscle atrophy. We'll work on those things, the muscle atrophy. Numbness is the last thing to get better, and that can take several months to get better. But the idea is to get you back to life and back to function as quickly as possible. We're not going to try to hold you back on these things. We want really to get you back to doing the normal things again.
That's fantastic. And so getting back to life again, the next question that I have is just about that. Is yoga bad for this condition? And would that be something they could get back to after their disc replacement?
So no, there's no reason you can't get back to yoga after this. Again, the disc is going to function normally again. So we want you to get back to normal. We want you to preserve the rest of your disc, the rest of your muscle function. So we want you to get back to do that. So after disc replacement, you get back to yoga at 10 days. So back to the normal kinds of things that you want to do. We want you to keep working on your core. We want you to keep working on all the other muscles and tendons functions that you have to prevent any further injuries from other issues. But specifically in the neck, we want you to maintain your strength that's there. So we really encourage you to getting back to yoga, getting back to all the things you want to do.
And tagging on to that, the next question was about jogging. I assume that's the same thing. You could get back to jogging as well.
Exactly, the same issues. We really want you to get back to life. So we got a normally functioning motion segment, we call it. So the disc functions normally again. We really want you to get back to that normal activity again. If we're kind of the thought process, if we tell you we're going to fix your neck, but then you can't get back to the things you enjoy, have we really made you all that much better? So we really want to try to get you back to the life that you enjoy by fixing this.
The last two questions really are about the same thing. So I'm going to read them together and ask, both of these individuals had neck fusions in the last year or 2 years, and they're not feeling any better. They're taking some pain medications or having epidurals to help manage the pain still. Do you think that they would be a good candidate for the M6 disc replacement, or what kind of treatment do you think would come next?
But the next thing to do is to help define the problem. With fusion, there are several things. One, it may be that it's as good as it's going to be. And as we said, that there is a 10% or so chance of still having pain at 2 years after their surgery. Less with a disc replacement than with fusion, because it doesn't move the same. It's not the same function as we would expect for a disc replacement as a natural disc. So the fusion is a little bit different, provides a little bit different stressors there in the neck. So first you need to define that. Is it because that's as good as it's going to be, or is there some other issue? Were the nerves completely decompressed? Did the bone actually fuse? Did it actually heal? Or did it put stress along the disc above and below, and now those are going bad? So we got to define that problem first. Is it the other discs? Is it the current issues, or is there other problems that are happening? So doing a new MRI scan or CAT scans or myelograms in order to determine what's going on there. If and or when we figure that out, then we can decide, is this something that can be fixed with a disc replacement, or is this other issues that need to be addressed?
Perfect. We did have one last question come in, and then we're going to wrap up for the evening. Are you the only surgeon at OSC who does the surgery?
Currently, yes, but Dr. McFarland will be doing this as well. So yes, this is like I say, started back in 2019. So we've been progressively increasing the number of these that we do because it is a great surgery. So we're slowly bringing on surgeons to perform these type of procedures that are really beneficial to patients.
That's great. We wanted to say thank you all for your questions. You had really great questions tonight. This evening's lecture has been very informative, and I hope that you have found the answers to your questions. Dr. Carlson is accepting new patients, so if you would like to make an appointment with him, the information is on your screen. You can call our office, and the best way to get to the appointment, is option 5, or you can also make an appointment on our website. We will call you to finish all the final questions, like getting your insurance right. We are located in the Port Warwick area of Newport News, very convenient to most areas around here, and we welcome patients from all over the extended Hampton Roads area. We do accept most major medical insurance companies. We do keep an up-to-date list on our website. There's a tab for insurance at the top if you would like to take a look at that. And to learn more about Dr. Carlson, Orthopaedic and Spine Center, read articles written by Dr. Carlson, you are welcome to visit our website at www.osc-ortho.com. Thank you all for joining us this evening, and we look forward to seeing you in our office soon. Have a great night.